start. Okay, hello and good evening everyone. My name is Alfonso Guaron and I would like to welcome you all to this webinar on current myeloma diagnosis, guidelines and techniques. So as part of the MP educational program, this session aims to give an update on the current optimal approach to myeloma diagnosis, as well as a comprehensive review on the available diagnosis techniques. The talk will be given by Dr. Guy Pratt, Honorary Consultant Hematologist at the heart of the England NHS Foundation Trust, and Senior Lecturer in Hematology in the Institute of Immunology and Immunotherapy of the University of Birmingham. Dr. Pratt, on behalf of Myeloma Patients Europe, I would like to thank you for finding a gap in your agenda to share your knowledge with us today. So for your information, this webinar will be fully recorded and then uploaded to the Myeloma Patients Europe website, which is www.mpeurope.org. So before we get started, I would like to make a brief summary on the webinar dynamics. This webinar is scheduled from 4 to 5:30, and during the first part, Dr. Pratt will make a presentation based on the slides, which will last around 45 to 50 minutes. And then I will open a session for you to make any questions that you might have. So there are basically two ways in which you can raise your question to the doctor. First of all, you can press the raise hand icon, which is in the panel of the application you just downloaded to join the webinar. And once you press it, I'll unmute your microphone when it is your turn, and you will be able to ask your question. In case your computer has no microphone, you can type your questions using the Q&A window, and I read it to the doctor on your behalf. So without further ado, I would like to wish you all a very fruitful session, and I give you the floor, Dr. Pratt, so you can start whenever you are ready.
Okay, so I'm going to present today the Multiple Myeloma NICE guideline, which was published in February this year, which is the National Health and Care Excellence body, which is the it's the organisation in the UK that gives access to treatments, and it also produces guidelines. So it's for adults with myeloma. It's excluded looking at MGUS or amyloidosis or plasmacytomas. So the group involved in producing this guideline were 6 haematologists, and that included a chair and a lead clinician, 2 clinical nurse specialists, 1 radiologist, 1 palliative medicine specialist, 1 palliative care clinical nurse specialist, and we had 3 patient and public involvement representatives, and they were 2 patients and 1 carer. For some of the topics covered in the guideline, we needed expert advice outside of the group, such as spinal surgeons and radiotherapy advisors. It's a lengthy process. We had 13 meetings. Some of these were 2 days. And then once we produced the guidelines, we published these as a draft, and we received comments about the guideline and made alterations as needed. So this was the myeloma guideline. We couldn't cover absolutely every topic related to myeloma. That would be impossible. So we developed what was called a scope, and a scope means that you identify the key issues and questions and come up with a set of areas or questions that we would look at. Once that was agreed, the guideline development process would begin, and each topic would be dealt with in turn and involved a literature search, and then a presentation of the evidence and development of recommendations. But as I said, once we completed a draft guideline, it went out for comment and we revised it accordingly. So I'm a medical doctor, so some of this was new methodology for me, the idea of scoping. So normally in the past when we've written guidelines, we've tried to cover all areas of the disease, but we were just focusing on particular questions. We had this system called a PICO, where we'd identify the population that we were focusing on and particular interventions, comparators and outcomes. I'll come on to that later. It's very important to link evidence to recommendations, and we had to demonstrate how we did that. And we would grade evidence in terms of its the strength of the evidence, strength of the recommendation, and the quality of the evidence. We couldn't perform health economic analysis on every topic, but we did on a couple of areas. So as I said, scoping outlines why there's a need for a guideline. It identifies which topics and what specific questions. So I'm not going to talk really about drug treatments, as in the UK they'd already been looked at in individual what we call technology appraisals, where a drug is assessed in terms of its efficacy and quality of life outcomes, and judgment is made about funding or supporting funding for that drug. That did make it quite difficult in terms of us not really being able to discuss certain treatments along the myeloma pathway. The health economic analysis we limited to 2 questions, which were the use of imaging, what imaging techniques we should use. Obviously we have skeletal surveys, MRI, CTs and PET scans, so that was something we looked at in terms of health economic analysis. And the other thing we looked at in health economics was the management of spinal disease, comparing kyphoplasty and vertebroplasty to non-surgical management. So this is the way that the guideline was developed, and this is the way that NICE do guidelines. It's called the PICO approach. So they'll identify the population of interest, and here I've got an example of acute renal disease, and then they'll look at the list of interventions that can be performed for those patients. They'll compare them with each other, looking at the evidence and the outcomes, and they'll define what outcomes they want to look at. And that's the way they collate evidence and come up with recommendations. So this shows the process of formulating defined questions and looking at defined populations, interventions, and comparing those relating to defined outcomes. So the evidence is presented to us when we went to a meeting. The groundwork will have already been done. We'll be able to look at all the evidence and come up with recommendations. And the words that tend to be used are the words offer, which is a strong recommendation. Consider is used when it's a slightly weaker recommendation for a treatment, or do not offer if it's a negative result. That's shown here. So offer is something that we use to indicate a strong recommendation, and we'd use that if the benefits clearly outweigh the harms. and is likely to be cost effective, whereas consider is a weaker recommendation where the evidence is not as strong. Okay, so this just shows that the whole NICE process is very robust. We all have to declare what interactions we have with drug companies, and we were not allowed, if we had a strong relationship with the drug company, we wouldn't be allowed to speak on a particular topic related to that drug. So these are the key areas that were looked at in the guideline. There's an algorithm here. It looks very complicated. I apologise, but this is an algorithm for myeloma, suspected myeloma, and then we've got recommended laboratory investigations and imaging investigations. Then if we suspect it's myeloma, then there may be further investigations, which I'll go into, and then it follows a course here depending on whether the patients are suitable for intensive pathway with high-dose transplant or not. Okay, so this may seem fairly obvious, but in the guideline we're very keen to stress the importance of communication and support, not only at diagnosis, but at the beginning of each treatment, at disease progression, and then later on in the disease when treatment options are limited. We define what information patients should have related to the disease process, the nature of the disease, relapse-remitting disease, and in terms of outlook. And then information around the treatment, the side effects and potential benefits, and also around stem cell transplantation, information around the disease and its treatment-related side effects, and also about managing day-to-day life and how it's going to affect day-to-day activity, and what can be done to try and improve health, such as optimizing bone health and renal function, the importance of reporting new symptoms, the role of supportive and palliative care, and then how to access support groups. And in the UK, we're lucky enough to have Myeloma UK, which is a superb patient support group. We all realise the importance of psychological assessment. That's something that's difficult in the UK, as there's not enough access to psychological support. Or again, not just at diagnosis, but throughout the treatment. And then advising family members or carers about what services were available. Okay, I know my talk's about diagnosis, so this bit's relevant to that. Laboratory investigations for suspected myeloma. So we were recommending serum protein electrophoresis and the serum free light chain assay. We didn't feel that there's any need to do urinalysis at screening, except if this is outside the guideline, but you would do it if you suspected AL amyloid. The important thing was not to use these tests alone, they should be used together. But if you use them together, you will detect 99% of myelomas. We were advocating doing genetic testing, and therefore it was important that you use the same sample that you do when you're doing the bone marrow test. so that people only have to have one bone marrow aspirate and one fine biopsy. So we strongly advocated doing genetic testing. It's a big problem in the UK because it's not funded centrally, it's not funded by the government, so individual institutions have to pay for this, which is difficult in the UK because we're all have financial difficulties, but we strongly recommend and want to advocate doing testing. So what's written on this slide is that we would recommend doing FISH testing on CD138 selected bone marrow plasma cells to look at for the 414 translocation, the 1416 translocation, the 1Q gain, deletion 1P, deletion 17P. Less strong is looking for other abnormalities such as the 1420 translocation, the 1114, and hyperdiploidy. So the reason for looking for these abnormalities is to look at prognostic risk for individual patients. There's also a strong move to be doing monitoring of minimal residual disease by the technique called flow cytometry, or called immunophenotyping, whereby the bone marrow plasma cells are examined to look at the markers on their surface, so-called plasma cell phenotype. And the benefit of that is that you can use it to look for very small numbers of myeloma cells later on in the disease, so it's useful for monitoring. So that's another recommendation that we made. So if you have a patient with suspected myeloma, we should be offering imaging. We strongly felt that whole body MRI was the best technique. And if that was not available, then a whole body low dose CT. Now, this is a problem in the UK, it's a problem in most countries, in that the capacity and access to whole body MRI is very poor. But this recommendation was made to really try and take things forward in the UK, as it is the best technique in terms of picking up myeloma bone disease. Skeletal surveys still used quite a lot in the UK, but we recommended that only if whole body MRI or whole body low dose CT was unsuitable. The isotope bone scans are not useful in myeloma and can be misleading, so they were not recommended. So in the UK, we have what we call MDTs, or multidisciplinary teams, and they're teams of healthcare professionals that look after a particular disease or group of diseases. Usually it's hematological cancers. But any MDT specializing in myeloma, we made recommendations around who should be in that MDT and what access they should have to other services. So, as I mentioned, psychological support services, 24-hour acute oncology, so any patient coming in with an infection, for example, would have access, physiotherapy, occupational therapy, dietetics, and medical social services and critical care. Should also be able to have access to clinical trials and dental services in view of the problems potentially with osteonecrosis of the jaw. So that was at an individual hospital level, but at a more regional level, then there should be other services available, such as access for patients who require transplantation or renal support or management of spinal disease, specialized pain management, apheresis, radiotherapy, more invasive dental work, and early phase trials. So we did talk about management of primary plasma cell leukemia because that hadn't been touched in other guidelines, and we're allowed to talk about that. So we did recommend novel agents, either bortezomib or lenalidomide based, and high-dose stem cell transplantation for these patients. We talked about management of acute renal disease. The strongest evidence is for bortezomib combination, and it should be as a medical emergency, as it's recognised that earlier treatment is more likely to lead to reversal of renal problems. There's less data on drugs like lenalidomide, but they're probably also effective, and there's no evidence for plasma exchange. We discussed preventing bone disease, so there's clear evidence that patients should be on bisphosphonate, and zoledronic acid was the preferred one. Permethrinate could be used, and this is particularly relevant for people who've got renal impairment, where zoledronate may be contraindicated. Permethrinate can be given to patients with renal impairment, although it has to be given slowly and dose reduced. Sodium chloridronate is a less favourable option, but it can be used if the other agents are contraindicated. Before starting on a bisphosphonate, patients should have a dental assessment to make sure that they have adequate dental hygiene and no dental issues before starting on bisphosphonate. And the reason for that is because the risk of osteonecrosis of the jaw is increased in people who have who need dental work, so it should be carried out initially. Obviously, there are patients who need urgent treatment. Then the dental assessment should be done as soon as possible. It shouldn't delay treatment. There's obviously a debate about how long people should stay on zoledronic acid, and there's no evidence, unfortunately, but in many units give it for 2 years, providing the patients are in a plateau. At that point, then it may be stopped and restarted at relapse. But there's very little evidence in this area to define how long to continue on Zometa. Managing spinal bone disease. Spinal cord compression is an emergency that requires urgent MRI, and it was covered in another guideline. So this guideline was mainly around management of spinal disease, but not spinal cord compression. So intervention here could be with spinal surgery if it was felt that there was instability of the spine. In general, spinal surgery was avoided unless it was felt that the instability could only be managed with surgery. Other interventions for an unstable spine include cement augmentation and radiotherapy, and it's possible that you would use these together, not exclusively one or the other. But the decision around that would really depend on the discussion with the spinal surgeons and radiotherapy doctors. Patients without instability, we believe that cement augmentation was a very valuable technique, although there's a lack of data comparing it to radiotherapy alone. So we couldn't recommend one of these above the other. As regards preventing infection, this is another area we covered. We believe that we should offer people with myeloma the seasonal flu vaccination. and also the pneumococcal vaccination. There's very limited evidence, but there's some evidence to suggest that intravenous immunoglobulin replacement may benefit people having recurrent infections, particularly patients who are off treatment, where it's more likely to be effective. It's less likely to be effective in people who have been treatment. It's well recognised that acyclovir is important in patients on bortezomib to prevent shingles, and there's increasing evidence that it may be of value in people on high doses of steroids and immunomodulatory drugs. It's important that we should consider testing for hepatitis and HIV. There's evidence now that patients can get reactivation of hepatitis, particularly on the immunomodulatory drugs. We discussed the management of peripheral neuropathy. One of the most important points is to explain to patients what neuropathy means and encourage them to tell the clinical team about any new or worsening symptoms, because by far the best way to avoid neuropathy is to manage it proactively by reducing the dose or the schedule of bortezomib or thalidomide, and even stopping it if it becomes severe. So by severe, we grade the degree of neuropathy. We define grade 2 neuropathy with pain or grade 3 or 4 neuropathy as an indication to stop treatment, which may be temporarily, but it has to improve before we restart treatment. If it doesn't improve, then we may have to switch treatments. We discussed from managing patients who are on immunomodulatory drugs where they have an increased risk of developing thrombosis, and the agents we discussed were low molecular weight heparin. Vitamin K antagonists are less popular. We generally recommend the majority of patients to start on low molecular weight heparin. Aspirin has been looked at in trials. Because we felt that the weight of evidence was more in favour of low molecular weight heparin. We would consider switching to low-dose aspirin for people who are on immunomodulating drugs following them achieving a maximal response if they have no other high-risk factors. Making decisions about anticoagulants is very individual though, so you have to assess the practicalities and risk of each strategies. So we are allowed to use erythropoietin. Anemia is common in myeloma. It's important to exclude other treatable causes, but consider erythropoietin to maintain a level of hemoglobin which should not be above 120, because that increases the risk of having strokes or epileptic seizures. We discussed monitoring. We felt that patients with smouldering myeloma could be monitored every 3 months for the first 5 years, and that patients who have completed myeloma treatment and recovered could be seen every 3 months. However, this needed to take into account risk factors, so such as the genetics, whether they had impaired renal function and what type of presentation they had of the disease. At each clinic visit, it's important to assess symptoms related to myeloma and myeloma treatment, and also repeat biochemistry, full blood count, bone profile, serum immunoglobulins and serum free light chain as well. And I feel strongly you should be checking serum immunoglobulins and the serum free light chain assay both at each visit. There's no place for routine imaging, it should be indicated by symptoms. The only exception to that is if there is an abnormality detected on a previous scan that may need follow-up. If patients are relapsing though, it's worth considering performing future cross-sectional imaging as a diagnosis. And similarly for patients with smoldering myeloma and disease progression. We're allowed to discuss a second autologous transplant. There's been recent evidence that this was of benefit for patients who had had a good response to their first transplant, and therefore we made a recommendation to offer this to patients who were suitable for a second transplant who completed reinduction therapy, particularly if it was more than 24 months. Between 12 months and 24 months it was less clear, and we used the word consider rather than offer for this group of patients. So patients most likely to be suitable for a second transplant would be patients who'd had a good response to the first transplant, a lower international staging system stage, and had good overall fitness, had not had many prior treatments, and generally had good cytogenetics and FISH. We discussed allogeneic stem cell transplant. Less than 1% of patients in the UK have an allogeneic transplant, so it's only a very small group of patients. And the reason is because of the risks to the procedure, which are considerable, and therefore there's a long list of important assessments that need to be made when considering an allogeneic transplant. In general, it only works in people with chemosensitive disease. You need to have a donor available. There needs to be a detailed discussion about risk, because the risk is high, particularly from what we call graft versus host disease, where the new graft attacks the patient, and the risk of early death compared to the potential for longer-term disease-free survival with the newer agents. Ideally, it should be done as part of a clinical trial, although often there's no clinical trial available. So there were two cost-effective analyses that were performed. I'm not going to go into detail of these, but what we did is we compared patients with suspected myeloma. We compared just going straight for a cross-sectional imaging technique and not doing a skeletal survey, compared to doing a skeletal survey, which often meant that patients then underwent cross-sectional imaging. I'm not going to go into detail about the cost effectiveness, but we felt that we showed that this pathway was actually as cost effective as doing skeletal surveys and then having to do cross-sectional imaging later on. One of the important points about this, of course, is that this will only be cost effective if the patients have suspected myeloma. In other words, if they have MGUS or are unlikely to have myeloma, then it becomes less cost effective to do more and more cross-sectional imaging. So that's an issue with doing cost-effective analyses. So it's very unlikely to be cost-effective if it's done as a general screening tool for all patients with a PAR protein. It's only likely to be cost-effective if it's for patients who are truly suspected to have myeloma. We also looked at the cost-effectiveness of balloon kyphoplasty and vertebroplasty compared to non-surgical management. Again, this is an area where there's very little evidence, but it was felt that this was a cost-effective technique. Research recommendations. So these research recommendations hopefully may be taken forward by the various funding groups in the UK. We felt it would be value to look at the new heavy light assay, which is from an assay looking at the involved immunoglobulin versus the uninvolved immunoglobulin, and looking at the ratio in patients with newly diagnosed myeloma, and to see what prognostic value that was. We also felt that there needs to be more comparisons of the different imaging techniques, whole body MRI, PET-CT and low-dose CT, as there was a lack of comparative trials in this area. We also felt that there ought to be studies looking at the group of patients with smouldering myeloma to try and identify better how to risk stratify these patients, looking at a whole combination of prognostic markers. And this is important as there's increasing evidence that perhaps patients with very high risk disease would benefit from treatment. And also, if there were trials to be done in this group of patients, what sort of treatment would be best, whether giving continuous treatment or for fixed duration. It's a question about allogeneic stem cell transplantation. And again, how does it compare with autologous transplantation and consolidation and maintenance with the newer therapies? And then a question about the duration of giving bisphosphonates, which is a meter, should be given indefinitely or for a fixed duration. So the guidelines were published in February. We've tried to promote these. And it's interesting that hospitals will look at these guidelines. They will question their physicians and doctors as to whether they're following them. But there does remain problems with capacity and funding issues, particularly regarding imaging techniques, access to MRIs and CTs and PETs, genetic testing, and also the availability of psychological support. So these guidelines will be reviewed every 2 years to try and keep them up to date. Okay, thank you very much.
Okay, thank you very much, Dr. Pratt, for this comprehensive review of the NICE guidelines. We have received a few questions from our audience. I would like to remind you all that if you would like to make your question live, you just have to press the raise hand icon in your application, or as some of you did, send me the question by writing. So, Dr. Pratt, I'm starting with to read the first questions, which comes from Thomas. And he says, from your perspective, are there many differences between the guidelines developed in England and the ones that are performed in the rest of Europe?
Sorry?
So
I missed that, sorry.
Okay, no problem. I will repeat the question. Thomas asks, from your perspective, are there many differences between the guidelines developed in England by NICE and the ones that are performed in the rest of Europe?
I'm not that familiar with the guidelines in the rest of Europe, I'm sorry. I'm not sure that there are many other countries that are producing guidelines apart from the UK and the International Myeloma Working Group.
Okay. So I'm going with the second question that comes from Michael, and he's asking, are there any significant differences when measuring the economic impact of a diagnosis technique compared to a drug or to a drug combination?
Are there any, financial?
Significant difference when measuring the economic impact of a diagnosis technique compared to a drug or a drug combination?
In general, there is very poor evidence. There's not usually very good quality evidence that makes it easy to do an analysis of how something like a CT scan impacts on patients and financially how it impacts. So there is a difference, I think, because for a drug it's absolute in a way. It's either yes, you're allowed to prescribe it, or no, you're not, in the UK at least. Whereas for things like imaging and diagnostic techniques, it's much more of a local issue as to whether you can have access to the particular technology or not. It's in a way it's less regulated, if you like. It's more regulated at a local level, depending on what your hospital scanners you have and whether the radiologists are happy to allow you to do it.
Okay, thank you very much for your answer, Doctor. So next question comes from Anne, and she says, regarding the last publication of the International Myeloma Working Group Guidelines, do you think it'd be convenient to add the measurement of the minimal residual disease at the time of the bone marrow aspiration as part of the standard of care?
Yeah, I do think that that's important. Unfortunately, when these guidelines were written, I don't think there was as much evidence, but minimal residual disease is going to become a way of assessing response that's probably likely to become the most important in clinical trials. So I think minimal residual disease results will become the end point of a clinical trial, and I think it is important information for any patient to know what's happening to their minimal residual disease after a treatment. It helps give you information about how good a response patients have had and allows monitoring.
Thank you, Dr. Pratt. Next question comes from Barbara, and she asks, would it be recommended to use a PET scan as an imaging technique at any certain point in the patient journey?
To use a PET scan as what, sorry?
If it would be recommended, as you did mention in the presentation, she asked if it would be recommended to use the PET scan as an imaging technique at any certain point in the patient journey.
I mean, PET scanning is one of the three. So we've got whole body MRI, low dose CT, PET scanning, and so there's a need for research to compare the three. The benefit of a PET scan is that it's one of the better techniques for monitoring. So it can be used later on in the disease to compare with the original PET scan. For example, it can tell you what areas have responded or whether new areas are apparent. So it does have some additional value which a low-dose CT doesn't have. There are MRI techniques coming along which will hopefully be able to use in monitoring as well, but they're less developed. So PET scan does have some advantages. It can show up areas of active myeloma, it can show areas where myeloma may have been before, but if it's not showing any activity, it gives you additional information that there's probably no new disease in particular areas. So it does have a value in monitoring. For certain types of myeloma, particularly if you've got plasmacytomas, PET scan is the best technique to use.
Great, thanks. Thanks for that answer. Dr. Pratt, we still have time to receive more questions. We have 3 left, so in case all of you who are connected, please, if you want to send more questions, just do it through the 2 ways, raising your hand or just send it by the chat. So the next question comes from Ben, and he asks, is there any consensus on the follow-up pathway of patients who have had at least 2 relapses?
Well, no, I agree with having a shorter follow-up. So certainly I wouldn't allow some of my patients to be seen every 3 months. I'd see them more often than that. If I was concerned about their disease and whether it was going to come back sooner than 3 months. So the 3 months was really, I think, the longest that you can leave patients between visits for people who've had treatment. Obviously some of our patients we see monthly.
Okay, thank you, Dr. Pratt. We have 2 more questions left. The next one comes from Luis, and he asks, taking into account the recent approval of novel agents for the treatment of myeloma, such as the second generation proteasome inhibitors or the monoclonal antibodies, do you think that the current guidelines would require a review in the short term?
Yes, they do. I think it's important to be aware of the situation in the UK, in that we're, I don't use the word battling with NICE, I think that's probably the wrong word. We want to work with NICE, but they work in a very slow way, and drugs like daratumumab, which is clearly an exceptional new drug, they'll be very slow to get round to assess it and give their judgment on it, and that's very infuriating in the United Kingdom. But yes, I mean, these new drugs like carfilzomib and daratumumab are definitely the best new drugs that we've got, and we should be trying to get access to them as soon as possible.
Thank you for your answer, Dr. Pratt. I think this doesn't only relate to NICE, because it's a problem that is currently happening in the rest of Europe, so don't feel alone about that. So, well, our last question comes from Mary, and she's asking, you mentioned that the allogenic stem cell transplant may be a suitable option for a reduced group of patients. And she asks, could you specify which group of patients might still have a benefit out of this treatment?
So it tends to be younger patients because of the toxicity of the procedure. Patients need to have disease that responds to treatment, so it needs to be what we call chemosensitive, so that when we do the transplant there's minimal amounts of myeloma around. We know that if you do transplants for any blood cancer, that there has to be good control of the blood cancer before we do the transplant. So younger patients with chemosensitive disease, we don't usually do a transplant as first treatment, so it's usually at first relapse, and it's a very risky procedure. So the one massively important issue is making sure that the patient is aware of those risks and would be willing to accept the risks of going into a transplant, because it's unlike any other procedure for myeloma with significant side effects with the procedure.
Okay, thank you very much, Dr. Pratt. So it seems that was the last question. And I have to say that I think it's been a very fruitful and interesting webinar, and I'm pretty sure that our audience has now a much better understanding on how myeloma is diagnosed and treated now in 2016. So, Dr. Pratt, on behalf of Myeloma Patients Europe, I would like to thank you again for sharing with us your valuable time. I know your agenda is pretty tight, so thank you very much. And I would also like to thank you all for joining us today. And just to remember that the recording of this webinar will be uploaded in the upcoming days to our YouTube channel and our website. And finally, I encourage you to stay connected with us and follow our upcoming activities in our website and social media channels like Facebook and Twitter. And finally, I also strongly recommend you to check our member section so you can be in touch with your local myeloma group just in case you haven't done it yet. So we are looking forward to meet you soon in our next webinar. And once again, thank you very much for trusting Myeloma Patients Europe. I wish you all a very good evening. And once again, thank you very much, Dr. Pratt.
Thank you.
Good evening. Bye-bye.
Bye.